I'm James Gwilt. I'm a GP and I'm the Clinical Director for Your Health Partnership PCN, which is in Sandwell in the West Midlands. In 2019, our STP delivered a PCN development programme with NHS RightCare and the Dartmouth Institute. 8 colleagues from the PCN attended the programme, including a GP, the lead AMP, a social prescribing link worker, a community services leader and a representative from the local council adult services. The core message that we took away was that patient preferences matter. As healthcare professionals, we often assume that we know what's in the best interests of our patients when designing and delivering healthcare services. Many of the unwarranted variations in care and outcomes that we see across the system have their roots in failing to understand patient preferences. The programme taught us that when clinicians focus on patient preferences and work together to deliver what individuals want, need and value, we give our population the best chance to optimise their health and well-being and can use the resources that we have more efficiently. Now, this isn't a vague or a woolly concept, but actually one that can be measured in almost real time through quite simple, short questionnaires. And I think that PCNs are uniquely placed to understand patient preferences and have the opportunity to become what's called the learning front end for the rest of the system.
I'm Rachel Hebbers and I'm the lead advanced nurse practitioner for Your Health Partnership Primary Care Network, and I also took part in the PCN development programme. Our chosen population focus for the programme was housebound people who live in their own homes. Our PCN had an existing dedicated AMP-led home visiting team, but we'd noticed that many of our patients were very high users of the team service and also of the local community services such as district nursing. We felt therefore that there was an opportunity to better integrate our response across the system, but also to work differently to address some of the underlying drivers of high service use. Before the programme, we had considered developing services to help our housebound patients with diet, exercise and alcohol reduction. When we actually asked if this is something they would value, not one of our 150 respondents actually said yes. Instead, they told us about their loneliness, their desire to maximise their independence, spend time with friends and loved ones, and to be pain-free. We realised that our patients needed to have their voices heard in order to achieve these goals. Our network social prescribing link worker contacted our 100 highest service users to find out what individuals value and help them to find solutions. The results have been amazing. Individuals have managed to leave the house for the first time in 18 months, have been connected to local community and befriending services, and many have gained confidence to manage their medical conditions without needing to contact the PCN so often. Our link worker now actively brings the patient's voice to our redesigned multidisciplinary team meeting, which has transformed the way we approach patient care planning.
I'd highly recommend the programme to any PCN that's considering taking part, and it's no exaggeration to say that it's transformed our approach to service redesign, and at the moment we're working on a PCN-wide strategy to put patient preferences at the heart of everything that we do.